Steve Wilson is going to talk to us about the role of Descemet's membrane in modulating wound healing, and anytime Steve's on the podium, people listen. So,
well, thank you. Thanks for the invitation from the organizers. Are we seeing any slides here? We don't have any relevant financial disclosures to this talk. I want to thank my fellows that worked on these projects, especially Carla, one of our other major talks, and she's this year's Troutman Award winner, and you'll hear about her other work this afternoon. We worked for many years on the role of the epithelial basement membrane in corneal scarring fibrosis, and recently our work has turned to Descemet's membrane because of a fortuitous series of experiments that I'm going to describe to you. We do know that late haze, PRK, fibrosis is a common occurrence, even in patients using we use mitomycin C with. In the rabbit, which is a more fibrotic animal than the human, if you do 9-diopter PRK without mitomycin C, 100% of them get this anterior fibrosis, whereas a 4.5-diopter PRK, the same procedure except for a lower correction, none of them get this late fibrosis. We also see the fibrosis in other situations, such as buttonhole LASIK flaps, at the edge of the LASIK flap, the donor-recipient interface in transplants, and scarring that occurs after microbial infections of the cornea. We published several years ago that it's the epithelial basement membrane that's the important modulator of this fibrosis in the anterior cornea. And we showed that in B, in a 4.5-diopter PRK, the basement membrane with lamina lucida and lamina densa reforms by 1 month after the surgery, whereas in a 9-diopter PRK, no sign of the basement membrane is regenerated, and this leads to the development of these myofibroblasts that are the cause of the late fibrosis in the cornea. You can detect these myofibroblasts with their marker, alpha smooth muscle actin, that we see in C here, a band of these myofibroblasts. And the reason they accumulate there is because they're absolutely dependent on a source of TGFbeta. And you can see the staining for TGFbeta 1 in the unwounded cornea below, and it's always present in the epithelium with almost none in the stroma. After a wounding of PRK, you get a little expression in the stromal cells, but it's still much more common in the epithelium, and if the basement membrane's intact, that TGF-beta can't penetrate at sufficient levels to drive and maintain these myofibroblasts. Myofibroblasts come from both the keratocytes and bone marrow-derived cells, which are called fibrocytes. We were interested in doing some studies where we didn't use PRK as our wounding model to show that it was relevant to other things, and we tried a Pseudomonas infection model in rabbits, and we're able to get major fibrosis in these animals. You can see in the right-hand panel, staining for alpha smooth muscle actin went almost, but not quite, all the way through the cornea at 1 month after surgery. We noticed in some of these corneas where the infection went all the way through, that after 2 months, the anterior fibrosis had disappeared, corresponding to the regeneration of the anterior basement membrane. But at 2 months, there was no resolution of the posterior fibrosis, and if we went farther out, it still didn't regenerate by 3 months or 4 months in the posterior cornea. This is a blood vessel where a parasite stained for alpha smooth muscle actin. It's hard to control Pseudomonas infections, so we decided to go back and just wound preferentially the endothelium, and we did it one of 2 ways, either using a smooth tip cannula to just enter the endothelium and retain Descemet's membrane. If we did that, we got the edema in the central cornea, but once that edema cleared in the rabbit through the proliferation and motility of the endothelial cells, there was a complete return to corneal transparency by 1 month to 3 months after surgery. Alternatively, if you remove both Descemet's and the endothelium, this doesn't occur, and you get severe fibrosis in the cornea that was persisting at the latest time point we used in the study of 4 months. When we stain these for the markers for keratocytes, which is keratocan, you can see if you remove the endothelium only, all of the cells in the stroma are still keratocytes expressing the keratocan marker. But in the corneas that had Descemet's endothelial removal, the anterior cells remain keratocytes, but the posterior stroma is full of these myofibroblast cells stained for their marker, alpha smooth muscle actin. You can see the periphery of one of these injuries. It ends right at this point where Descemet's membrane was excised. An interesting finding in these corneas is the fibrosis is dynamic. It's not a static thing. Cells are continually becoming myofibroblasts as other myofibroblasts are disappearing by apoptosis. The farther away from the anterior chamber cells are, the more likely they're going to undergo a tunnel assay positive apoptosis, whereas the closer they are to the anterior chamber, the more likely they're going to proliferate, as signified by Ki67 staining. Here's the model of this injury. If you remove Descemet's and the endothelium, TGFbeta from the aqueous humor that Wayne Stryline showed long ago was present in high concentrations, leaks into the cornea, causes the development of these myofibroblasts from both fibrocytes from the blood and keratocytes in the cornea. So the source of TGFbeta is the aqueous humor. The rabbit endothelial cells can proliferate. If we followed them for 2 years, some of this may have been reversed by proliferation and regeneration of Descemet's membrane. We don't know. What is the clinical relevance of this? If you're doing DSEC and DMEC, you want to make sure that your graft is covering the entire exposed area of stroma, not leaving a gap in Descemet's membrane where you can generate fibrosis. In cases of dislocation, repair them promptly. And desmetorrhexis, some people are proposing that for Fuchs dystrophy. You need to be careful with that when you don't replace with endothelium, because some of those corneas, not all of them, can develop fibrosis, and that's actually been reported in the literature. Thank you for your attention.